Already. Well, thanks, Clark, for this topic. It was not easy. Those are my disclosures. But I guess you told me because I'm the young guy, that's what we get. That's fine. Before I go any further, I just want to say that, stress everything they say this morning about this, echo and the relationship in the operating room. I basically moved to Nashville 8 months ago, and I took everything from ECU, kind of transplanted it there. We took them there, they saw how we did it. We took Dr. Sherwood's sheet of all the measurements, and basically that's how we do mitral repairs, exactly how I learned at ECU. And on the case on Monday, we're testing the valve, and there's a little leak, and the perfusionist goes, are you going to close the cleft? Because we do it robotically, everyone can see it. So to the point that basically the anesthesiologists, everyone in the OR, they know what we do, they know how we do it, it's reproducible, and I think if you can get the team to buy into this, then you can make it successful. And I think the minimal invasive approach, whether it's with a camera or with a robot, I think makes the room buy into this. They all can see it, they all learn it, and it's a great experience. Now, I'm going to switch to this healthcare economics, which I really don't know much, and I can tell you Puerto Ricans are not great at any economics, and we have never been. We just take all the money from the U.S. and we use it. And
what about drugs?
But I don't know why Clark gave me this. But this. I'll tell you. I'll go at it.
Puerto Ricans. No.
So basically, no matter which way you slice it, if you look at here, this is healthcare expenditure, and that big bar is the United States. And we basically are deviating from everyone. We spend more money than anyone else. And the question is, well, if we spend more money, are we any better? Well, if you look at here, the return on investment, this is looking at longevity. The U.S. is out here. We spend a lot of money, but we don't live any longer than any of these people. So when you look at return on investment, our return on investment is not great in terms of survival, okay? So, and the more that we do and the more technology that we bring in, now the question is going to be, what's the value? Is it worth it? And what is that we're getting out of it? If you look at growth of the health expenditure, so how much money we spend, and you look at different eras, so 1980s to 1990s, and you move on, this red is the national expenditure, and this is the GDP. Every time GDP goes up, usually, and this is basically annual percentage change. So every year, this is how much it went up, 14%, 16%, 12%. So this is not that it's going down, it's that every year the percentage has decreased a little bit, but it matches this. But if you see from 1980s to now, actually, the expenditure increase per year has decreased. I mean, we're still spending more money every year, but we're doing it at a slower rate. That's one thing. And the other thing that you can see in terms of GDP, and you see between 2008 and 2010, that was the crash on the market, so obviously GDP goes down, and then finally the expenditure kind of plateaus in terms of percentage. So the growth, meaning how much money we spend per year, percentage-wise, is lower than it was in 1980s. We're still spending more every year, but it looks like it's plateauing. And there are many reasons for that. Payers have something to do with that, and patients, and I'll show you on this graph, kind of looking at that. So there are three things. Let me see, this laser is not projecting there. I can use this. There are three things that basically determine expenditure. So this is personal health care. This is how much each person spends. And if you look, this is from 2000 to 2006, and that is, again, percentage growth per that period of time. So here, people were spending 7.6% more in that period, and as you move, then 5% and 3.7%. So again, the message is people are spending less money per year in terms of the increase. And if you look at the use and intensity, which is the last bar, the one that is 3.3, 1.4, and 0.1, basically what it shows you that in 2010, the use and intensity of healthcare significantly went down. And there are a few reasons for that. One, they talk about the flu season was less than any other year, so that was, and the other thing is people have no money to go to a doctor. So people are not going to see their family practitioners, they're not doing. This is not good, that 0.1 is not a good thing, but that's the reality. The other thing that happens too is there's a variation between regions on healthcare usage, and we know that. If you look at PTCA, CABG, PTCI, AVR, mitral, so one would be kind of the average, but there are places that are here. In PTCI, you know there are places that are here. That would be the Marylands and other places who got in trouble. And the government and insurance companies, they look at this variation. I guess from the talks from today, if you look at tricuspid valve repair, there are a few centers that are way up there compared to everyone else. And again, I think those things, we're going to have to explain them at some point based on outcomes, and I think that this variations have to change. That's the way we push the envelope. This is how we learn, but we're going to have to explain that. The other thing that I want to point out is, and this is because as I moved to a new hospital, the administrations come in and they say, well, why is it that you do robotics? Why do you use this ring? Why can't you just do it cheaper? Why do you use the endo balloon? And so on. One of the things that I like to remind everyone that actually a huge cost in healthcare is hospital administrators. And if you look at this, in 1999, this is basically published in the New England Journal of Medicine. The cost of healthcare administration was $294 billion, which was $1,000 per capita compared to $300 in Canada. And the reason is because of this. If you look at spending per capita, and this is the cost of administrators, the total cost is $1,000.59 versus $300. When you look at how many employees it takes to take care of 10,000 patients, any insurance company is around 13 to 20 people versus in Canada is one person for 10,000 patients. So again, one of the huge costs of this healthcare is hospital administrators. So when you meet with your CEO, CFO, CNO, any old that you can imagine, that's another person that is diving into your ring or whatever it is that you want to use. Okay? So that's kind of the basics on healthcare economics. That's as much as I know. If anyone knows more, please tell me, but that's pretty much it. Specifically for cardiac surgery, the good news for cardiac surgeons is that cardiac surgery still makes money. And it makes, compared to any of the other specialties in hospitals that do cardiac surgery, it is 26% of the profits. So still, as a heart surgeon, you have a lot to say to the hospital in terms of we are still bringing profit to the hospital. Now, they have to use those profits for other programs like pediatrics or ER, and that's where it gets a little muddy. Plus, you have to use those profits to pay all the hospital administrators again. But again, keep that in mind that you're still making money. Now, the reality of a cardiac surgery program is that if you look at CABG, and like Dr. Che would used to tell me, if you're going to live on the last coronary from Rocky Mountain, which is 45 minutes from where we are, your program is going to die. So if you're counting that CABG and it's what's going to carry your program, that's going to be a problem because it's going to continue to decrease every single year, no matter which way you slice it. And if you look at CABG and PCI, they're both going to go down, and the rate is around 3% per year for each of them. And that is the estimates, and we've seen it. You're going to continue to see that. Plus, there has been a dilution of the number of programs. So there are more programs doing coronary bypass surgery. And what happens is that the volume per center continues to go down. Every time you have dilution of services, we know that the more you do, the better you get, the more efficient, the more cost effective. So by doing any of these things, you're going against to. So you really want to try to be in centers where you can actually increase your volume, get good at it, and get better. And if you look at this is the change between 1996 to 2007 in CABG volume basically went down by 33%. During the same period, valve surgery went up 31%. So basically we have traded one for the other. And if you're in a place that you don't see these changes, then there's going to be a problem because this is going to continue. The valve is going to continue and the CABG is going to continue to go down. And when you look at the distribution, basically mitral and aortic is the higher one, and we know from TAVR that has continued to increase. The other good, the other prognosis, basically valve surgery and the procedures are going to go by 18%. The other thing in cardiac surgery or in cardiovascular services that is going to go up is ablation for AFib, and AFib admissions are going to be, and programs have to start looking at what is it that they're going to offer for AFib, but that is just, those are the two areas that are going to kind of go up, valve surgery and ablation. And I'm not talking about surgical ablation for MIS, I'm just talking about AFib management of those patients is going to go up. If you look at the prevalence of moderate or severe aortic and mitral disease, so if you look at here and you look by less than 45, 45 to 54, so these are the ages. Obviously, as they get older, it increases. So you have 8.5 to 13% of the patients have moderate to severe disease, which is around 3.7 to 5 million people in 2007. By 2030, it's going to be 6 million to 10 million people. So, and as Dr. Bowling said this morning, if you look at even very good institutions and their cardiologists, they pound their chest and say, we send all our patients early, the reality is that is not. And we have seen that at our place. Every single place, when you dig for these patients, you find that they're not being sent early on. The other good news about valve surgery is that if you look at the contribution to profit or the CTOH, if you look at contribution to overhead, valve surgery still makes more money than anything else that we do, whether it's CABG or drug-eluting stents or permanent pacemakers. So depending on which institution you look and which center, it's anywhere between $13,000 to $25,000. And there are huge variations between one center and the other, and I think that you really have to go and find out at your institution what is the cost, what is your CTOH, how can you get better. Because if you do it proactively with the administrators, I think that they're going to take that better. When you look at the contribution of CABG alone, it's around $12,000, but when you look at valves, it's in the $17,000 range. And the percentage of the volume is 53% CABGs, but if your choice is to do one valve or two CABGs, you probably start looking at how to increase your, in terms of profit, you should be looking at more valve surgery. And when you specifically look at mitral valves, since we're talking about mitral valve surgery, a repair, the contribution is $19,000 versus a replacement that is $13,000. So if you can pick your poison, you want to do a lot of mitral valve repairs. That is really what drives the money. The other thing about valve and CABG, so these two curves, these two pie charts, they look at payer mix. So if you look at A is CABG and B is valves. Actually, very good payer mix for valves. So you have 58% are Medicare and 36 are private insurers versus CABGs that are 32 and 54. So most of these people, they're working, they have insurance. So from the payer mix, it's very favorable too. But when you look at how much different hospitals in different places make out of heart surgery, so you can say, well, the average is $19,000, but really what happens at different places? This is a study from 2008 looking at many hospitals, 300 and something hospitals with different volumes and everything, and what they did is they looked at how much each hospital was making, what was the range. And you can see that the length of stay varied from 11 days plus minus 7, and comorbidities changed. But when you really look, and what they did is they took the cost of valve, and this was for aortic valve replacement. So aortic valve replacement for all patients, the cost was anywhere between $21,000 and $95,000. This is the Medicare payments, which is basically, the cost for the Medicare patients and the cost for the private patients. So the cost for private patients is a little bit lower. There usually are younger patients. Medicare patients tend to be older, so obviously it costs you a little bit more to do a Medicare patient. But when you look at the contribution to overhead, some hospitals are losing money. So $14,000 for all patients, and some of them are making $47,000. For the Medicare patients, they're losing $20,000. So there is something specific to each hospital that you have to really look into it and say, are we losing money? Are we making money? What can we do to make it work? So from the cardiac surgery economics, cardiac surgery accounts for 26% of hospital contribution to profit, and that is certainly different in hospitals that are doing 2,000 heart operations versus hospitals who are doing 100. But in general, it's profitable. CABG and PCI will continue to decrease, valve surgery will grow, and it's profitable at this point. And the question is, and what Clark wanted me to address was, minimally invasive valve surgery, is that something that is profitable? So these are the two choices, and basically anytime we do something, the question is, number one, is it safe? And can we do the same thing? And then we'll look at the cost. But just to put cost first and just get it out of the way, basically when you're talking about going from a sternotomy approach to a minimally invasive approach, what you're doing is you're adding instruments and retractors, so that's a one-time buy, and you're talking anywhere between $50,000 and $60,000 to get all your instruments, your retractors, your scopes, whatever it is that you're going to do. Anesthesia equipment, the only thing that is a little bit different is a double lumen trickle tube that you would use for some of the cases. But in general, there's not much you're going to change there. Where the cost of minimally invasive is much different between one approach to the other is really on perfusion systems. If you use the endo balloon, the entire heart port platform, and you put a retrograde, an endovent, and an intraocclude, that's $8,000. If you use the Chidwick clamp and an antegrade cardioplegia, is $500. So, I mean, that is, I hope you give me some royalties for that clamp. Yeah.
You have some we can buy tonight, Dr. Chetwood, is that it?
He always has two clamps,
right.
Don't worry. So again, I think that, if you start with $19,000, that's what you're going to make, and you platform is the endo balloon and all, then it's simple math. And the other place where there's an increase in cost is in OR times. You saw all the minimally invasive series. Most of them will show that there's an increase in cross-clamp time and an increase in OR times. And then if you add robotics, then there's a cost of robotics. And then you can look at it in different ways. Most hospitals have a robot that is collecting dust, so it's there already. So actually, if you use it, it doesn't, they already pay for it. So the question is, can you make it work for you? So there are two studies looking at the robotic cost. So this one, basically they look at the cost of robotic ASD and mitrals compared to conventional, and basically robotics added $3,400. It's basically what because it's $1,000 for the disposables usually for any case, and then if you take the cost of the robot over 5 years for whatever they do, it ends up being another $2,000 or so. So you're talking about $3,000 extra for that. And then there's another study that basically show pretty similar numbers. So here is the conventional surgery, here's robotic surgery. If you look, the intra-op cost, which is the lower bar, is higher for robotics, but the post-surgical cost tends to be lower because these people are in the hospital a day less usually, and then there's some less blood transfusions and things. But here what they show was that the cost for a conventional operation, and this were all mitral valve surgeries, mitral valve repairs, the cost was $18,000 for the robotic cases and $17,000 for the conventional. So not a big difference. Now, they did not include the capital cost of buying a robot. And that's the huge thing. So if you take $2 million and then you say, okay, I'm going to take those $2 million and I'm going to put them over however many cases we do it, then obviously the cost is much higher. So what I did is I went to our hospital and I said, tell me how much it costs for, and every hospital has a cost center and they'll tell you, and these numbers, I don't know how they come up with them, but they come up with these numbers. If you look at a regular setup for the OR, so if I'm going to do a mitral valve, whether it's a sternotomy or basically they say the first hour is $1,900 and every 30 minutes is $467. That's the price that they have for it. If I do a robotic case, the first hour is $4,100, which is those kind of $20-something $100, $1,000 from the disposable, and whatever the hospital decided that is the cost for the robot. And then every 30 minutes is around $400, and I don't know why their salaries are lower for robotics. I don't get that part. But in general, that's what you're talking. You open that OR, the first hour is going to be $2,000 versus $4,000. And then every 30 minutes is at a clip of $500. So if your operations are taking an hour later, it's another $1,000 from their cost analysis. That doesn't mean that that's just basically the way they do their units. But again, I think if you know what you're dealing with, you can explain. So That's the cost of minimal invasive. And the way I see it is, you have a menu, and you can pick as many things of the menu as you want, robotics, endoballoons, this, and then you start, using the credit card, and then you stop whatever it is that you want. And it's with whatever you feel comfortable with. As far as safety, when I do this talk on complications, I think what you're doing when you're moving from the sternotomy to a minimal invasive approach, you're basically these are new things you get: retrograde dissections, lower extremity ischemia, liver lacerations, phrenic nerve injuries, superior vena cava, inferior vena cava lacerations, PA clamp injuries, LA retractor, all the things that we have seen in minimal invasive. And now you can look at centers like Dr. Chirwood's and Clark's, and I mean, these are extremely rare events, but they can still happen. And the only thing that you know for sure you don't get is a sternal wound infection. But otherwise, those are all the complications. But as you look at most of the studies, and there are 3 or 4 studies only really comparing conventional sternotomy to a minimal invasive approach. Some of them have shown that there's some decreased morbidity, decreased transfusions, decreased ICU, decreased hospital length of stay, early return to productive life, and that's very difficult. I see people that I do a robotic mitral valve, and they say, "Doc, I went skiing last week. I was so happy. Can you give me another 6 weeks? I still have disability. Can you sign this?" You can't compete there. If they have this, that's just not going to change. And then there is a volume increase. Everyone who has been successful at a minimal invasive mitral valve program or minimal invasive valve program in general, their volumes over the, if you look from the inception of the program to 5, 6, 10 years later, pretty much everyone has been successful at growing their volume. We saw it at ECU. We see it where I am now. Every place you're able to do that. This is a example of a clinic this is in LA, and they were in 1999, they were doing 15 valves. 2005, they opened a center. They were very active about, they're one of the first centers that published that people with severe AS were not being treated, and now they're, in 2007, they were doing 120 valves with a 95% repair, because you get good at it if you do more. So this has been shown that surgical volumes will go if you have successful programs. Now, as far as safety and potential benefits of minimal invasive, if you look at this is the 1,000 minimal invasive valve operations. This is from the Brigham, one of the earlier. They had their initial study with 50 patients on each group, and then they went to this 1,000. If you look at full sternotomy, mitral valves versus minimal invasive, 400 and 300 patients. The length of stay was a little bit shorter for the minimal invasive group, and the rate of discharging home was also lower. And pretty much and that was despite the cardiopulmonary bypass times being longer and the cross-clamp being longer. Now, this is a different approach. Most of them were parasternal. It's a different minimal invasive approach. And when they look at the cost, their cost was actually a little bit better for the minimal invasive approach. But again, they weren't using this hardboard technologies. They weren't using the robots and other things. This is another study. Basically, this is from Colombia, and basically they're showing the same. 1-2 days less in the hospital compared to the conventional. This is Will Ryan's paper, where basically he was able to control match patients. This is a retrospective study. It's looking at matching a sternotomy, and this is for mitral valve replacement. Length of stay for poor access was approximately 2 days less. Ventilation times were shorter. Reoperation for bleeding was shorter. There was no difference in blood transfusions, which is something that is being thought that is something beneficial, and our blood transfusion rate at ECU for robotic surgery was around 20-25%. So lower than we see in most other series, but again, he was not able to show that. When you look at mitral valve repair, and he compared mitral valve repairs, this is sternotomy versus poor access, he showed the same thing. 2 or 3 days less in the hospital, less ICU, less ventilation. So all of those things, if you apply any economics to that, will transfer to some cost improvement that may offset those costs of the minimal invasive. This is Joe Wu's paper looking at robotic series comparing to conventional, and again, he showed a benefit in blood transfusion and a benefit in shorter hospital length of stay. So the potential benefits are decreased morbidity, decreased blood transfusion, decreased ICU and hospital length of stay. And the question is, so what does that represent in terms of cost? How much does it cost to be in a hospital an extra day and so on. So if you look at this is basically a paper looking at what complications cost. So septicemia, around $50,000 per patient, any infection, $30,000. I think this ARDS, $16,000, reoperation, $15,000. And every time you have a complication, you're going to increase the cost of that hospitalization. So in theory, if you have a platform that potentially has less complications, you should be able to reduce the cost. This is the same. This is used in the Virginia registry. When you look at any, this is for CABGs, so any complication, AFib, mediastinitis, reoperation, all of them increase your hospital length of stay. So any of those things will do it. And when they apply the cost, so if you had a patient AFib, that was another $12,000, mediastinitis, $62,000, stroke, $34,000. And I think the stroke is something that we have to talk a little bit because, you know, if you look at Gammy's paper, there's some question about minimal invasive having higher strokes, although we know that there were some flaws just because you can really capture what true minimal invasive and the perfusion techniques. But again, obviously that would be one thing. If our stroke rate is higher with minimal invasive, then the cost is going to be $34,000 per patient, and it may not be beneficial. As far as how much a day in the hospital costs, I think that's sometimes a little funny, but if you look at a few studies, it's anywhere between it's around $2,000. I looked at IAS at our hospital. What is the cost for one hospital length of stay? $2,500. So when they do their calculations, and we looked at our robotic cases, so I looked at a few robotic cases versus sternotomy patients, the length of stay was 2 days less. They're putting $5,000 on their benefit. That's all funny money. If you don't put another patient in that room, I don't really think they benefit that much. They still have the nurses. They still have the electricity. I mean, there's a lot of things that go into these numbers that are kind of funny. But that's how they do it. This is from the advisory board, and they're looking at variations between the 25th percentile and 75th percentile performance in hospital length of stay for cardiovascular patients, and it varies between, for CABG, it's around 3.7 days between the people with the best length of stay versus not, and it costs around, you know, $3,400. So again, extra days cost you more. And as far as blood transfusions, this is a study looking at blood transfusions and cardiac surgery, and the cost of it, basically any patient that gets a blood transfusion, that adds at 1.4 times to whatever the cost would have been if they wouldn't have blood transfusions. So, and it may be because it's associated to other comorbidities and all that, but again, if you can decrease that, which is one of the things that has been shown, it may be a way that you can offset the cost. So again, I think, you know, minimal invasive mitral valve surgery will continue to grow, and it's been every year there are more centers and more successful surgeons doing it. It could potentially increase your volumes. So I'm in Nashville, and basically there are 2 centers doing mitral valve surgery, Dr. Petrasic at Vanderbilt and us, and really that's pretty much it. And again, if you don't have, at least in that city, if you don't have someone doing the repairs and doing the minimal invasive, you may not be able to change the volumes from one place to the other. In Philadelphia, every center has a minimal invasive surgeon. In fact, I don't know anyone doing mitral surgery there or having a big practice that is not doing minimal invasive surgery. The benefit of decreased morbidity is still, you know, we really don't have a good study showing that. And it would be decreased ICU, length of stay, decreased blood transfusions, how you can offset some of the costs. And again, I think you really have to partner with your hospital and really see what's the cost, how can you make it better, which things you should implement. Take into account this is a balance. If this is what you can make, and these are all the things that are going to potentially drive this up, so this 19 will become higher if you can increase your volumes, decrease ICU, but it's going to be at the expense of your instruments, OR times, cannulation platforms, and robotic costs. So you got to pick where is it. And the only way you can do it is diving into this data at your hospital. Every place is different. I'll be happy to answer any questions.
What do you think, Dr. Chitwood? Can you give Karen, give him a For you, yes.
Very nice talk, Villy. You know, it's hard to get these data. And I'll tell you, a lot of hospitals, it's hard to get the information. You're trying to help them, even if you're a hospital employee. You're trying to help them, and you say, how much do you charge, and how much does it cost to do a blood transfusion? And they say, well, you know, we'll tell you how much we charge. So it's really hard to drill down the exact data. And I would say in the robotic thing, the best thing to do is to be in a situation where urology, GYN, everybody else is using it, so that basically you're not the villain for the cost of the robot. It's about $1,000 if you don't have to amortize the robot. So it's not that much more expensive to use the device if you don't count the device itself. But I think the key thing is we're going to have to get these prices down, our costs down. There's no question about it. Industry will have to come down as well, and especially with this, what's coming down with the Obama plan, we're going to have to get the costs down a lot because the profit margin is going to be way, way down. You know, my hospital is asking us to try to take $200 million out of their budget, to find a way to take $200 million out of the budget, you know. Well, of course, everybody says you take it out of his budget, you know, not my budget. And that's going to be the real cost. I do think the minimally invasive stuff, if you do it right, it does give you less hospitalization. It does give you less blood loss. You know, as my partners say, well, 6 months later, it doesn't matter, the scar, a little teeny scar versus big scar, the patient's doing just as well. But I still think there are some advantages to doing things minimally invasively. But it's really hard to drill down and get this data. I think you've done the best that you can do. I know that Joe Bavaria did a really nice drill down on TAVR, but he had the Wharton School of Business
They did it, yeah.
to help them do it. You saw his talk down in Dallas.
Yeah.
It was a fantastic
Really
talk.
good.
It's the best drill down that I've seen on anything.
Ever.
But I don't think we all can do that kind of drill down.
Hey, Randy, in JAMA last week, there was, and I caught a lot of press, was about, you know, minimally invasive GYN surgery, predominantly robotics and other stuff, showing that it was more costly, outcomes were not any better, nor was morbidity less. So is that going to influence, you know, this, or is it because people are just doing it? I mean, patients want it. Patients want it.
Versus
Laparoscopic.
Yeah, versus laparoscopic. And that's a different thing. If you compare laparoscopic versus open, that's really the big comparator. I think that one thing that with robotics, it's advantageous to the surgeon as much as it is to the patient, in that you really can see very well, like I talked to Robert about Robert's operation this morning, that it really is facilitating. And once you get your team organized, that's the key. You know, a very well-known surgeon in this room who is a great mitral valve repair surgeon asked me this morning how long it would take him to get up to speed. So it wouldn't take me long to get you up to speed, but it's all team because you know how to repair mitral valves. This is just a pair of scissors, you know, $1 million pair of scissors. And so it's true. It's a device, it gives you access. So, you know, you certainly can do things very well, minimally invasively, with direct vision or with long instruments. But I think you can do this the least invasive way using robotics. But, you know, that's my opinion, and only time will tell. The test of time will tell if we're right about this.
Your opinion, you're going to stick to it. Steve?
That's right.
So, Billy, that was a great talk. Let me ask you, so the robot's been around 17 years in cardiac surgery. So I've heard this same talk for 17 years now. Maybe it's good, maybe it's bad. And I'll ask you that a lot of the comparative studies have been, the ones that you showed are really bad studies. Will Ryan's study had an 11% mortality in the standard mitral. Holy mackerel.